So thank you very much, Pat and Karen. I appreciate the chance to come and talk to this class, which I think is a great class. Here you can see are the smiling students. I think last year is at the end of the course. So that's how you will look at the end of the course. Wondering when the sun is going to come out, probably. So anyway, my assignment is to talk about what is global health, what's the relevance of global health for people who are interested in developing diagnostics, particularly point-of-care diagnostics. So I'll do my best. And first of all, you don't have to scribble because you will get this handed out later. And actually, I think it's better without handouts because then you have to look at what's being presented. These are four of my favorite websites on global health. One is the UW Department of Global Health website, which we're very proud of. One is the Kaiser Family Foundation website on global health. There's an interesting one called Gapminder that if you haven't seen it, you really need to look at it. You can see dynamic versions of this. And then finally, World Mapper, and I'll show you some examples of pictures from that. This is the Gapminder world chart. And what it shows is on two scales and over time, how different countries compare and evolve as the level of income increases, for example, the gross domestic product, as other things change, and how that relates to evolving improvement in mortality rates and other indicators of health. And Hans Rosling was out here a couple of months ago showing this, and it's just fascinating to see. So have a look at it. Someday you'll be able to look at charts that show here's where diagnostics for malaria were introduced and here's how mortality fell. And another important thing to look at is this recent report on smart global health policy that came out from the Center for Strategic and International Studies. So these are a few references. Now, what is global health? And if you look at the top here, it used to be that we called the field tropical medicine, and then it became geographic medicine when Rockefeller began to invest in it. And then for a while it was known as international medicine. And the term global health came into common use about 5 years ago, and that's the current term. One of my colleagues says the term is going to last for 25 years. We'll see. That was about 5 years ago. What it really implies is global interdependence for health. Not just what health is like in another country, but how we are all interdependent in health. And it's not really a discipline like epidemiology or chemistry or lab medicine. It's more a broad field that tries to enable every kind of discipline to work more effectively internationally. Why has there been this tremendous explosion of interest in global health? It's certainly, I think, the fastest growing area in medicine and public health. And one reason is the growing interest in and awareness of the importance of equity and how the income gap, the so-called Gini index, is getting wider and wider between the rich and the poor, and how that's related to the survival gap between the rich and the poor. And then the appreciation that health is really a critical development issue, not just investing in poverty reduction, education, and so on, but health per se is a development issue. And then there is this growing awareness and concern about the threat of global infectious disease pandemics. SARS, bovine spongiform encephalitis, H1N1 flu recently is what captures much of the public attention. And then, as I'll summarize for you, there are impressive new resources for global health that finally are allowing us to do things that can make a difference. And then lastly, young people, many of you, and faith-based organizations are feeling that working in this field is the right thing to do and it's the smart thing to do, and we really can make a difference in this area quickly. So there are a lot of hurdles you have to get over in working in global health. This is what I call the acronym pandemic. And just so you don't get too nervous, I don't understand half of these myself. And I could spend an hour looking at things I'm currently reading and come up with an equally long list of acronyms not on there. But don't let that intimidate you. So what I'll try to cover in my talk is what are the major global health agendas, what are the present and future challenges in global health, and where are the emerging opportunities. In going through this, I will emphasize but not only talk about infectious diseases and a little bit on diagnostics, although my talk on diagnostics will be tomorrow. So we usually talk about 3 global health agendas, but I think there really are 5. First is the communicable diseases agenda, and this is sometimes called the unfinished, but we would imply more finishable agenda. I think it's really an unfinishable agenda because the bugs keep evolving faster than we do. And the priorities here are HIV/AIDS, tuberculosis, malaria, NTD is neglected tropical diseases, EID is emerging infectious diseases like SARS, ARI, acute respiratory infection, and diarrhea. And it's hard to keep our leaders with their mind focused on more than 3 things at one time. So we tend to group things like NTD as one entity rather than breaking them all out, for example. The next is maternal and child health and reproductive health and family planning. And that's considered a more finishable but also unfinished agenda. Recently, the Gates Foundation, Melinda Gates in particular, attracted a lot of interest and enthusiasm in announcing that the foundation will be investing $1.5 billion in this area over the next 5 years. And there's been a lot of interesting progress in this area. Third, as you'll see on some graphs I'll show you, that injury, accidents, violence, including violence against women and war, are what I call the permanent structural or policy-driven prevention agenda. Actually, we sponsored a course, a symposium here just 3 months ago in April on global health and war that attracted students from all over the West Coast, and it was quite interesting. One of the things that the Gapminder displays indicate is for those countries that have been able to stay out of war, their progress along the income and health graphs has been much faster than those of like us who are continuously at war. Fourth is the chronic disease agenda, which focuses on aging, nutrition, obesity, diabetes, tobacco smoking, and cardiovascular disease, cancer, mental illness. And finally, the future, although not so distant future, eco-health agenda, which includes climate change, overpopulation, migration as population grows, depleted water, poor sanitation, food, and related problems in health. So there are various ways of prioritizing or looking at these things quantitatively. This shows the global burden of disease, or in terms of disability adjusted life years, or DALYs. For 1990, you can see that the #1 cause of DALY loss was lower respiratory infection, followed by diarrheal disease, both infectious diseases, perinatal disease, depression, ischemic heart disease, cerebrovascular disease, tuberculosis, measles, traffic accidents, congenital diseases, malaria, and so on. But things are changing fast, and by 2020, globally, the top of the list is going to be ischemic heart disease, followed by depression, and further projections to 2030 have mental illness at the top of the list in terms of global burden of disease. And you can see road traffic accidents moving to the top as well. And the infectious diseases coming down. Now this is the shape of things to come. I like this. This was on the cover of The Economist. Now where are you on this graph? This is, I guess for those of us, I wish I was in this category, who are there, are really not fully evolved. This is the fully evolved guy over on the right. Now, the burden of disease and disability adjusted life years varies by region. And you can see on the left that for Africa, communicable diseases still account for 70% of DALYs. South Asia and the Eastern Mediterranean, it's about 40%. But for much of the world, including the high-income countries and the Americas, you can see in Europe that it's the chronic diseases that are the most important. Injury is important wherever you are. There's been an attempt to classify the 10 best buys for health. Where would you get the biggest bang for your buck? And you can see the 10 here. Those in red are infectious diseases. And neonatal mortality, healthier mothers and children, and recent reports indicate things are getting better. Mortality is dropping for mothers and children. Good nutrition, reducing deaths from cardiovascular disease, stopping the AIDS pandemic. I wish I could say we're making a lot of progress there. Stopping spread of tuberculosis, similarly. Control malaria, tobacco use, injuries, and ensuring equal access to health care. And a subsequent effort, just a couple of years ago in Copenhagen, was to identify very specific investments that would have the biggest bang for their buck. And so 7 of them are listed here. The first is very relevant for diagnostics. For tuberculosis, appropriate case finding and treatment. And the benefit to cost ratio is 30-1, with a big impact on disability-adjusted life years lost. Next is heart attacks, management of acute MIs with low-cost drugs. Third is malaria, both prevention and artemisinin combination therapies. Then childhood infections with improving vaccine coverage. Then cancer, the chronic diseases, cancer, heart disease, and other. And here the biggest bang for the buck is with increasing taxes on tobacco. I've been reading somewhere that it's costing $10. How much does a cigarette pack cost nowadays? I read somewhere it's about $10 a pack, or getting there.
Just went up to $19 in New York State.
$19, wow. Well, in some ways, maybe that's the only way. New York is ahead of the rest of us. And then for HIV, the concept of a combination prevention package. And lastly, the combination of what district hospital surgical capacity deals with, acute injuries, difficult childbirth, and other surgical emergencies. So those are areas that a lot of us are putting a fair amount of thought into and emphasis. But I think the 2 biggest priorities are not listed there, and they are education of women, young females, and optimizing contraceptive coverage would have a huge impact. Now this is from the World Mapper project. You go to that website and you can find 600 or 700 of these slides that are really interesting. This particular slide depicts the area of the country according to the size of its population. But as we go on and look at malaria deaths, this is an amazing slide. It shows you how incredibly concentrated malaria deaths are in Africa, particularly in sub-Saharan Africa. And this shows tuberculosis cases, again, showing the concentration in Africa, but also in southern Asia and China. This is HIV prevalence. Here, North and South America and Europe have at least a little bit of depiction on the map, but again, hugely concentrated in Africa now, throughout Africa, and in South and Southeast Asia. So that's a quick look at where these unequal distributions of some major infectious diseases are located. There's been an effort to look at what, for the things that we have available now, how well are they scaled up? What's the coverage of the population? So for clean water, I think this is an overestimate, but it's estimated that 80% of the world population has access to that. For sanitation, only about 60%. For the vaccines, the common vaccines, polio, measles, and DPT3, it says 80%, but there's been a paper, if you see down at the bottom footnote, Steve Lim from our department published an article a year ago showing that the reported coverage by these vaccines was actually overreported by about 30%. For reasons that are unclear, but possibly because there's an incentive-based payment, performance-based payment, where the more you report that you vaccinated, the more money you get from Gavi. Not everybody likes that analysis. This is hepatitis B virus, 60% coverage. Haemophilus influenza B, very low, 20%. For micronutrients, vitamin A is about 70% coverage. Iodine, only about 65%. Fluoride is very insufficient. Directly observed therapy, single dose treatments weekly for TB is 60% coverage. Modern contraception, or it's directly observed therapy short course, I guess is what DOTS stands for. Modern contraception, less than 60% coverage. Insecticide-treated bed nets is only 20% of the areas that need bed nets for preventing malaria are getting them. Safe blood is only about 20% or less, and tobacco abatement policies is like 5%. So it's amazing, although tobacco use peaked about 10 years later in the developing world than in the developed world. It's beginning to come down, but only about 5% of countries have tobacco taxation policies. For child health, the major causes of death are pretty much all infectious diseases. Neonatal sepsis, acute respiratory infection, diarrhea, measles, malaria, HIV, AIDS. And hence the major prevention priorities are infection related. So preventing tetanus by immunizing the mother, childhood vaccine coverage, nutrition, especially the micronutrients that have an impact on some of them on infectious diseases, safe water and bed nets, pretty much targeting infectious diseases. And then we have the threat of pandemics. And this slide came out with the advent of SARS. And I knew that the time had come for protecting ourselves from infection when I also used to always lecture to the medical students making rounds in the hospital about the importance of washing your hands or using the alcohol substances on the wall. And 3 of my students at the same time pulled out their little bottle of Purell. And I'd never seen anything like that. So they are thinking about it increasingly. And why the increase of these emerging infectious diseases or pandemics? The WHO has said that 2 million people in the world cross borders every day. And this is the world air traffic flow chart, which depicts, as of 2002, the number of air traffic routes that are intercontinental, with 35,000 such routes that year. Now, there were 335 newly emerging infectious diseases from 1945 to 2004. And of those, 75% were zoonotic, meaning spreading from animals to humans. And here's why. A friend of mine was studying a form of chlamydia that was transmitted amongst pigs. And he got this picture, and just about that time SARS came out, and I gave this picture to a couple of people. And pretty soon everybody in the world had one of these. And soon you'll have one of these. And you know, it isn't just pigs. There's mixing with animals that occurs in many venues. Now, switching to the chronic disease agenda, this is the Lancet in 2007. No serious conversation about global health can take place now without at least citing chronic diseases as a critical part of international health strategies. Here's a woman smoking, and an important article that sort of summarized what are the interventions, what are the top 3 priorities. And here is tobacco control, salt reduction, and a multi-drug strategy to prevent cardiovascular diseases. And I'll say a little bit more about that. Next is what are the best national policies to get us to reduce consumption of saturated and trans fats? We really don't know how to do that yet, but that's a goal. And then there's this concept of the polypill prophylaxis against hypertension and cardiovascular disease, which actually has been, there have been feasibility studies and intermediate outcome studies that I'll summarize. Here's one, the Indian polycap study, so-called TIPS, published last year, looked at the effects of a pill that contains aspirin in low dose, a statin to lower lipids, and antihypertensives and risk factors in middle-aged people for developing cardiovascular disease. And this particular study showed a significant impact on intermediate outcomes like blood pressure and like lipid levels. There has so far not, to my knowledge, been a study showing that taking this on a regular basis will actually prevent cardiovascular disease morbidity, mortality. And in fact, there are data now that taking a single baby aspirin every day in people who haven't yet experienced cardiovascular disease doesn't reduce the risk of cardiovascular disease. I haven't studied this, but I saw that come out last year. And then we shouldn't forget mental health, particularly early recognition and treatment of depression, which, as I indicated, projected by 2030 to be at the top of the list of causes of disability-adjusted life years lost. And climate change, mitigation and adaptation. Weston came up with this, quote, fiddling while the globe burns, which has sort of been our approach globally to dealing with climate change, basically talking about it but not doing anything about it. And so what does climate change actually have specifically to do with health? And there was a nice article in Lancet last year that's cited here that listed the specific things that we can think about trying to mitigate and adapt to. Changing patterns of infectious diseases, changing vectors for infectious diseases, dengue recently coming into southern U.S., food safety and security, water quality with water becoming depleted, countries that are already dry becoming deserts, and related problems with sanitation, difficulties with shelter and human settlements, and then with extreme events, extreme floods, drought, and heat, the resulting mortality. And then finally, the emergence of mega cities as the population continues to go up. People move from the rural areas to the city, and you get these huge slums that are outgrowing our ability to design cities. So we adapt and not just mitigate by things like flood control, vector control, thinking strategically about water systems, food security, and adapting to heat and dry land. We've formed a working group between the College on the Environment and Department of Global Health and a variety of other departments at the University of Washington now to begin working specifically on water systems and food security, to begin looking at what are the opportunities, what are the needs. Here's an example of where the slum growth is occurring, and it's not in the United States, as you can see here. Again, it's in Africa, Southern Asia, and China. Here's an example. I saw, who's from Kenya here? I know there's somebody from Kenya. And Kibera is said to have represent the largest slum in Africa. And it illustrates what's happening in infectious diseases in some ways. It's been shown now by a US CDC study in Kibera that the commonest cause of fever in children under 5 is Salmonella typhi, typhoid fever. But interestingly, on the eastern coast of Kenya, along north of Mombasa, it's been non-typhoid Salmonella bacteremia that has been spreading rapidly and now is the commonest cause of fever in kids, with the emergence of so-called pseudogenes and multi-antimicrobial resistance occurring in these emerging Salmonella typhimurium strains. And I can't get away from these pictures of animals and humans drinking together, so there's another one. And here is a picture of, an industrial mega city in the south. It raises the question, what population can the Earth actually support? Currently around 7 billion people. And a friend of mine who was a classmate in college who was with the World Bank for years had a paper recently saying that it was probably about 3 billion. He had some rationale for that. But if you think about it, if it is something of that order of magnitude, how are we going to go from a population of 7 billion to 3 billion? How are we actually strategically going to do that? And by when? Reproductive health is clearly a critical field. So in terms of global health and in view of this agenda, what are the priorities now? What do developing countries actually need? Well, I've begun making a list. So in terms of workforce capacity, we can note that medicine is one. Our Department of Medicine has over 30 specialties. Public health has about 5 to 10 specialties or departments in schools of public health. Nursing, pharmacists and pharmacy techs, dentists, social workers, community health workers, laboratory workers. And then there's a need for equitable allocation of funding across the continuum of development, education, health, poverty, and infrastructure. I'll come back to that one. And then there's a need for better health leadership, management, and policy training, prioritized by medical schools in Africa. There's a need for integrated health systems development, public health systems, tertiary hospitals, to district hospitals, to health centers, to health posts, to certified laboratory systems that I think Bob Martin will probably talk to you about. And then we need access to the health systems through roads and transportation, logistics and supply chain management. And then there's a need for financial and material resources to actually build this. And a part of the IMF and World Bank structural adjustment policies are undergoing reversal, and more of that is needed. There's a need for salaries for healthcare workers in the public sector. We need to provide pharmaceuticals for conditions other than HIV/AIDS. Equipment, I put diagnostics in yellow. We need adequate safe water and sanitation, nutrition, adequate food, housing, adaptation to climate change, information systems. And I had another list that was twice as long as this, but I just put et cetera because I ran out of space. So we need to think about what we're doing, where you fit in, against all of this background of what is needed in these other areas and how you can connect to these other areas. We all tend to think that our own field is the field, but in fact there are enormous needs and we need to figure out how to connect. So there is, for example, in capacity development workforce, an estimated shortage of almost 4.3 million doctors, midwives, nurses, and laboratory workers, and community health workers worldwide. This shows a slide of where physicians are working, and what is so sad about this is you can see that there are plenty of physicians working in North America and in Asia. I'm sorry, in Europe and in Asia. But look at Africa. I mean, that's where things are really pathetic, and Indonesia as well. So there's a new emphasis that everybody working in any area of health needs to know about. This is a World Health Organization publication from 2006. It isn't the latest word, but it's a good initial guide. It certainly applies to laboratory system development, other health systems development. And it's where more and more people want to invest in what's going to get done, whether it's application of point-of-care diagnostics or how they're going to connect to other types of testing. But it isn't all bad, and there is really an enormous potential for making things better through increased efficiency and effectiveness by integrating our health systems. And this is a key issue for point-of-care diagnostic screening. And I'll just give you this one example. A friend of mine in a Latin American country that I won't name has been evaluating a rapid test for syphilis, the Abbott Determine test, and in antenatal patients. The idea is to link it to rapid testing for syphilis and HIV, so both would be done together. HIV, fairly uncommon, syphilis, fairly common. And what she's found out is that in antenatal patients, there were 23 forms that had to be filled out from various funding agencies, from the local government, from the regional government, from the hospital. Some of these were forms designed 20 years ago and no longer in use. Some had to do with how the patient was going to get their care paid for. But it took 6 visits before all these forms were filled out and the women could actually get the results of their rapid point-of-care test. So think about it. This is for the HIV test and the syphilis test. How is your test going to actually be integrated into primary care systems, whether they're for maternal health or other types of care? It's doable, but it means that you've got to work with other people to make it happen. Here are some pictures of the existing infrastructure. A clinic on the upper left where people line up 80 patients in the morning, and what's inside is an empty laboratory and an empty pharmacy. Hospital wards overcrowded, people sharing beds or sleeping on the floor or having beds in a church. This, Bob, I hope this isn't one you were going to be showing, is it? Because I got this from Bob Martin.
No.
Good. This is one of my favorite slides for those of you who work in laboratories. Down in the bottom on the right is the Zeal-Nielsen staining, I guess. But here is a safety hood on the top. And you notice that open pipe ventilating into the room as opposed to outside shows you there's something wrong with that hood system. So there are lots of new opportunities, and I'll list a few of them. There's this explosion of interest from academia. There are new technologies that are very promising and much more coming, and you're working in that area. New resources from government and from foundations. There are emerging public-private partnerships for global health, and professional organizations that many of you and I belong to are going global. And then there are new strategies. So in academia, this shows the trends in the number of university-based global health programs, showing a 300% increase between 1995 and 2008. We formed a consortium of universities for global health last year, and we had 8 members, and we are now up to 44 paid or pending members. We had 60 universities meeting at NIH last year. This was a statement from our own university president, Mark Emmert, which we liked. He said, in my generation, students did not want our nation having different rights for different people. But in your generation, students don't want our planet to have different rights for different people. So we're having a meeting of the Consortium of Universities for Global Health, the 2nd annual meeting here at the University of Washington on September 20th and 21st. And for students, it's almost free except for the lunch. So we hope some of you will be able to come. Here's our departmental website. And you see this map here. You can hit any area of the world and we'll tell you where University of Washington has a program going on. Here we go. More than 300 projects in 82 countries, just by our one department faculty. Many other departments have other programs. So in terms of new technologies and tools, in biotechnologies, the 2 hottest new vaccines are rotavirus vaccine, both from Merck and from Glaxo. Now out in the field, they've done well in the developing country trials and are having an impact in the United States, and will have an impact on infant diarrhea in developing countries, and human papillomavirus vaccine for preventing cervical cancer in women. Which of these do you think will have the biggest impact on disability-adjusted life years lost? Will it be the rotavirus vaccine in the kids? Or will it be, I see some people nodding, or the preventing cancer? It's going to be in the kids because they have a long life to live, and if they're dying, 15% of infant diarrhea deaths of rotavirus, and that's prevented by this vaccine, compared to the HPV vaccine, which is very important for women's health. We've got to get it out there, but it will have less impact, and it's right now a tougher sell compared to rotavirus. In terms of new diagnostics, we have rapid tests now for malaria and syphilis. And I'm going to talk tomorrow about centralized nucleic acid amplification tests that involve mailing of specimens, swabs, for example, or sputum or blood on filter paper from primary health care clinics in the field to central labs for diseases that don't need to be treated instantly, like tuberculosis, for example. Well, like malaria that needs to be treated instantly, where you can wait for a couple of days to get the results back by email. And then with information technology, there's a huge impact on distance learning, on surveillance, on clinical care, and on the use of diagnostics globally. And finally, we have the emerging generic pharmaceuticals that are available now at low cost, and increasingly the fixed dose pharmaceuticals, where you can have one pill that you take once or twice a day for your 3 drugs for malaria or your 3 drugs for TB, which I think is a real important advance. Now, this is what's happening to financing for global health. You can see that by disease, Ravi Shankar from our department reported this steady, dramatic increase through 2007. And they have new data projections through 2010, and I can't give you their unpublished data except to say that there are continuing substantial increases through 2010 for investments in global health, which is going to make a big difference for the kinds of work we all do. This is President Obama's Global Health Initiative budget, and it over the 6 years from 2009 to 2014 will commit $51 billion to HIV and TB through the President's Emergency Plan for AIDS Relief, and they hope to strengthen health systems simultaneously for malaria control and for other global health priorities, particularly maternal and child health, reproductive health, and neglected tropical diseases, which altogether will be $12 billion for a total of $63 billion. And that makes a huge difference compared to what used to be available. There are old and new perspectives on development, the sorts of things that USAID and the World Bank and the IMF do. So the old concept was first you targeted poverty, and then you strengthened infrastructure, and together that would lead to better education and then finally to better health. So it was like it was a continuum. But a new perspective on that is that they're all really interconnected, and that development in general involves investments in health, in infrastructure, in poverty, and education, and they each are synergistic. You really can't educate young people if they're not healthy, and it's hard to reduce poverty without having healthy people. So this is a relatively new concept that we need to take advantage of. So I've given you this big overview of global health today, and in summary, there are many problems. There are 5 major global health agendas, many needs, particularly population control, economic growth, gender equality and education, alternative sources of energy for preventing climate change, avoiding war and violence, infrastructure development, and workforce development. The new opportunities in academia, technologies, resources, partnerships, strategies, interest of students and faculties are very exciting. We are beginning to make a difference, and we can make a much bigger difference if we work together strategically and systematically, and that's what I'm encouraging. Lots of people are making a difference in global health. I tried to get a picture of Pat Totten and Karen Hansen and our PATH colleagues. What?
You don't have any room up there.
But, well, we'll work on it for next year because they are too, and you all will. So thank you very much.